To introduce
Recording in progress.
Dr. Brandt came to us as a PGY4 from the University of Utah, where she immediately made her mark. She was born in
the mic on.
She was born in Port Huron, Michigan, into a Coast Guard family and frequently moved across the coast in the Great Plains. She completed her undergraduate degree in biology at DeSales University, where she graduated magna cum laude. She then attended Pennsylvania State College of Medicine for medical school before matching at the University of Utah, where she completed her first, second, and third years before going on to earn her MBA. We were then lucky enough to recruit her here, where it took her less than a year to become the clear choice for admin chief. Her list of accomplishments, both academic and athletic, are extremely impressive. She's a literal All-American USAA triathlete. Last year was awarded the Earl G. Young Memorial Award for Clinical Excellence, and also can do a whipple on one leg. I'm especially grateful for her dedication to our program as an admin chief and honored to call her a co-resident. Our residents and patients will be blessed by her presence here for another year as a surgical critical care fellow, and I'm very much looking forward to her talk, Don't Wrestle the Pig, Leadership Lessons from Surgical Residency.
Good morning. Dr. Kendrick, before I started, asked if he was the pig, and I just want to make it clear that that's not the case. Before I get started, I wanted to put a small plug in for another part of the world that's having a little bit of a rougher time than we are. One of our residents here, Maria, is actually in one of the Northern Mariana Islands right now. They were just hit by a typhoon and they're having a hard time. So these are some links where we can sort of provide aid if we're able to. And also just sort of informal kudos to Dr. Brunswold's wife, who's actually deployed there and helping. Somehow they both ended up in the same country, at the same hospital, yeah. So keeping them in our thoughts. All right, and so Don't Wrestle the Pig, Leadership Lessons from Surgical Residency. So for background, I showed up in Dr. Belzer's OR at Methodist, and not knowing who I was, he looked at me and said, "So why are you here? Did you get fired or something?" And it made me realize that nobody really knew who I was or where I came from. I never stood up here as an intern and explained my life story. And so to provide context for what I'm going to talk about today, leadership, I'd like to tell you a little bit more about me. So my maternal grandmother was born in a part of Poland that's now Belarus. She fled Poland as a preteen during World War II, and standing at a whopping 4'9", she taught my mom, who taught me almost everything I know about resilience. And I'm the middle child of two brothers, and as you can see from the photos here, I've always been a little bit suspicious of the younger one. So my older brother, Nate, he's an engineer for General Motors. And one of the best parts of only having brothers growing up is that I got sisters later in life. So Nate married Jill this past year, and that's him with my grandmother. And Nick is my little brother. He's a pilot for the United States Air Force, and he married his USAFA sweetheart, Shanley, who's an intelligence officer, also for the Air Force. And earlier this month, they promoted me to aunt. So please meet Catherine June. And this is my favorite photo of my parents. Some of you may recognize this as the chapel at the Air Force Academy. My mother is a database administrator, and my father was a commander in the United States Coast Guard. Specifically, he was the commander of the Juniper, which is the ship pictured here. And so having such a left-brain family made for a really awesome childhood. I remember one Christmas where my little brother was gifted a mini drone, and he was flying it around the house. And my older brother was gifted a Nerf gun, which he rewired to a higher voltage battery, so it was really painful when he got shot with it. And being a military brat meant home was wherever my family was. I moved every 2 to 3 years for my whole childhood, and I think feeling like I was always about to do a big move was my childhood version of the Coast Guard motto, Semper Paratus. I credit this with making me a pretty adaptable person, and this is a photo of Commander Brandt and I, my dad. And so in the spirit of adaptability, in college, I took to the heptathlon. It's a track and field event that actually consists of 7 events, and you're scored across all 7. And the composite score is how you're ranked. It felt a little bit like training for the Hunger Games, but I really liked it because if you did something wrong in one event, you had to mentally recover really quickly. Otherwise, you were probably going to face plant in the hurdles. And so this is where I really got my first exposure to leadership. But at the same time, I'm not sure I really understood what being a leader meant or how to perform my role well. So fast forward when I matched to general surgery residency at the University of Utah, my dog Summit and I spent 3 years of residency and 2 years of research exploring the Wasatch Mountains. And here's where I really began to become a surgeon. I started to realize that even though I was learning to operate, I was still lacking insight into who I wanted to be professionally and what I wanted my career to look like when I finished residency. And that mug was gifted to me by my first intern when I was trauma chief. Still have it. So my professional development years are where a lot of this personal development happened and how I learned how I wanted my role as a leader to look. During these years, I started working with a triathlon coach and had the privilege of competing at the national level. My coach also specialized in work with adaptive and Paralympic athletes, and once I was fast enough, I began competing as a guide. Since then, I've guided several athletes with various adaptations to their sport, visual impairments, limb loss, mobility aids, etc. So in this process, I learned that I had a passion for the physical task of improving access to a sport that I was passionate about. And this is Josh, pictured here. I've been guiding him for 4 years now, and he has been the national champion in his adaptive group for all 3. But I didn't just race triathlons during my 2 professional development years. I also was academically productive, and I completed my MBA. And this was the first of really any of my previous opportunities to formally study leadership. And I credit my leadership education within the MBA for much of what you're going to hear today. It was during this time that I decided to transfer to the University of Minnesota in pursuit of more mentorship, professional and personal development, and also in pursuit of more robotics experience, which I've gotten plenty of. So this is a photo of my mom and I, and she was one of the first women in her family to go to college and was the first to get her MBA. And you're going to hear a lot of advice from Commander Brandt today, mostly because he's pretty silly. But it was really my mom's wisdom, empathy, and energy that has bounced and steadied me on the path to now. So the most important piece of information that opened the door to leadership for me was learning that it was a learned skill. It's not something that you're born with. And if you're not naturally good at it, you can practice and you can study and you can get better. So the practice of leadership is intimately tied to extensive research regarding the growth mindset, which is largely spearheaded by Carol Dweck. So Dweck outlines a growth versus fixed mindset. She described a fixed mindset as someone who believes abilities are innate or static and unchangeable. A growth mindset is the belief that abilities can be developed through effort, strategy, and feedback. So there are several studies that have proven this, and further, people who have a growth mindset are found to be more likely to seek feedback, adapt, and improve, making leadership a skill that's developed and rather than being innate. And so one of my favorite studies in this domain was actually the Duckworth study. They studied similarly to a growth mindset, the concept of grit and its relationship to leadership. So they performed a series of studies on high-achieving people, including West Point cadets, Ivy League grads, etc. And they found that someone's grit better predicted their success more than SAT scores, more than intelligence, and better predicted their ability to be leaders. So while I've never felt that I was naturally the best leader in the room, I do feel like I'm likely a contender to be one of the grittiest and maybe the most adaptable. And so this finding opened up the door for me to pursue leadership in the same academic approach that I approached surgery. So if leadership is a learned skill, then residency is probably one of the most challenging environments for us to learn it in. We're busy, we're tired, we're under pressure, and we're expected to lead at the same time. There's a troublesome mindset of, because it was hard when I went through it, it should be hard for you. In other words, do you want me to punch the other side and make it even? I'll be the first to say I haven't always gotten it right, but I found that having a framework has helped me get leadership right more often. So what I want to do today is start a dialogue about different tools we can use to help each other grow and become leaders as a team. So I hope by the end of this talk, I will have given you some answers to the question, how do we lead in high friction, high stress environments and leave the residency system better than we found it? And so this talk is going to be a summary of the relevant literature that has informed me as I've sought the answer to this question over the last 7 years. But before we begin, I think it's important to have a norming slide because I'm a female and I started residency when I was 24 years old. And so what resonates with me might not resonate with you, and that's okay. These perspectives are things from my experience, my MBA, and my family that I believe informed my leadership style during my time as a resident leader. These principles apply to all levels of residency, from intern year to chief year, but I also don't have so much hubris that I would look at Dr. Akramanen or Dr. Kendrick and think that I could teach them about leading a department or leading a residency program. This is also just an overview, and there's a huge fund of literature behind all of these principles that I'd be happy to discuss more offline. A great deal of my own personal research endeavors have been studying real-life applications of these principles, and the details of which are probably too granular for today, but I geek out over it, so I would really like to talk to you guys about it offline. Also, this talk is heavily informed by advice from Commander Brandt, because who doesn't need a little dad advice every once in a while? So let's get started. So I have 3 objectives for today. I'd like to discuss how resident leaders shape others, how resident leaders shape behavior, and then how resident leaders can shape systems. So let's start with how we can shape others. So the business chemistry framework is a framework that I use to try to optimize my workplace communication with you, my coworkers, but also you as my attendings. This framework was created by Deloitte. It's one of many frameworks that try to simplify how people think and work together. Others include the DISC, the MBTI, and the Big Five, but all attempt to answer the same question. Why do smart, well-intentioned people approach the same problem so differently? So this model resonated with me mostly because of how effective it has been at improving my own communication. It attempts to describe people based on working styles, not personality labels. People can move between them, and each brings value in the right context. They're really intended to describe how people prefer to give and receive information at work. So within the business chemistry framework, there are 4 working types: pioneers, drivers, integrators, and guardians. And if you want to learn what working type you are, Michelle sent a short survey that you can take, and it'll help give you an idea. But if you haven't taken already, you can take it after the talk. That's totally fine. But we're going to talk a little bit about each type. So pioneers tend to be big picture, idea-driven people who are more comfortable with risk. These people value possibilities. They're known for sparking energy, being outgoing, and being creative. And so for each of these, to kind of help cement them in your head, I've included some famous examples. So some of you might recognize this as Whitney Wolfe Herd. She's the founder of Bumble, and she created a novel dating platform specifically to meet the safety and comfort needs of women. And an even more famous example, Dr. Elfman. So Dr. Elfman is one of the many fantastic juniors I've had the privilege of working with this year, who I've used this strategy on. I've gotten permission from some of them to share their results, so they're going to be included in the talk today. But working with Ashton, I always knew that if a situation called for energy or momentum, she would step in and move the team forward without hesitation. And that's a pioneer. So when you're communicating with the pioneer, you want to start with the big picture and then go into the details. You want to praise their uniqueness and their innovation and appreciate their vision, their creativity, and their boldness. They'll be a little more sensitive to having their ideas shut down outright with no's and can'ts, and it's important to approach pioneers with a willingness to explore options and ideas. Drivers, on the other hand, tend to be results-focused, decisive, and goal-oriented. They value challenge, and they're often really direct when they approach people and problems. Some famous examples include Indra Nooyi. This was the first woman of color to run a Fortune 500 company, and she is known for completely revolutionizing the growth movement inside Pepsi Company. Many athletes also fall into the driver category. I've included Serena Williams as a noteworthy example. She's widely known for her intensity and her goal setting. And even more famous is Dr. Linden. So Dr. Linden was another one of the amazing juniors I worked with this year. He's actually a driver and a pioneer. And working with Dr. Linden, I always knew if he'd have a clear list of goals and a timeline, and he would take ownership and ensure things got done. No excuses or no reminders. And that's a driver. So when you're working with a driver, you want to be concise and you want to get to the point quickly. And I think we all know attendings who are like this too. You got to get it out in 2 sentences or you're going to lose them. You want to praise the driver's momentum, their decisiveness, and appreciate their ability to get things done. They also tend to be people who give really direct feedback, and it's important not to take that personally. Integrators are relationship-centered. They're empathetic and team-focused. They value connections, and they're known for being the glue of a team. They're consensus-oriented. Some noteworthy examples would be Michelle Obama, who had a huge emphasis on empathy and authenticity during her time in office. Malala Yousafzai is another example. She's a Nobel Peace Prize laureate, known for her advocacy for women's education. And most famous of all, working with Dr. Deneen, I always knew if the team needed alignment, support, or cohesion, he'd be the one making sure everyone was set up to succeed. And that's an integrator. So when you're working with an integrator, you want to praise their ability to keep people engaged and motivated. They tend to promote harmony and unity, and you want to emphasize that. Sometimes they may need reminders that you can't please everyone. And finally, guardians. So guardians are detail-oriented, methodical, and risk-aware. They value stability. They're known for bringing order and rigor, and they're deliberate in their decision-making. Some noteworthy examples: Ruth Bader Ginsburg specifically was known for this because of her legal reasonings were disciplined, methodical, and organized. Margaret Hamilton is one of the most famous computer scientists ever. She worked for NASA during the Apollo missions, and she basically made crewed lunar landings possible. And for those of you who have worked with me know I love a spreadsheet, an outline, and a clear deadline and an order of working events. And that's more classic for a guardian working type. So when you're communicating with a guardian, you want to be precise. Outlines with a logical order go a long way, and clear deadlines are helpful. You want to praise their thoroughness and precision and appreciate their commitment to quality and accuracy. You also need to understand that guardians work under a lot of self-imposed stress and high standards, and so fear and pressure should be used cautiously as a motivation tactic with people with this working type. So I'd like to reiterate that these are not steadfast. You can be detail-oriented and still be a pioneer, etc. These are truly a framework on working motivations, how you can tailor your approach with someone so that your communication is better understood. Further, leaders can use this as a tool to help their teams. Does my team need a pioneer today or an integrator today? So to anchor this in the business world, leadership at companies will often make a small biography that they distribute to their team, and it actually contains information like this so that their team knows at the outset the best way to communicate with them, which for someone like me as a guardian sounds like heaven. So if you've been on service with me as a junior resident or even as an attending, I've used this on you. And here's an example. So these green on-service slides are going to pop up throughout this presentation. The intention of these slides is to illustrate practical examples of how I've applied these leadership principles in residency. So, so I want you guys to imagine you're the senior resident in the OR with the junior resident and you're about to do a lap chole. It's a busy shift. The junior resident has a line of non-urgent consults pending and this awesome page from Jay and Pacquiao. You're in the OR and the junior resident comes flying in to get ready for the case with 5 different lists and 3 pagers. You want to make sure that the resident feels like they're able to be in the OR and learn without being too weighed down by all of the consults piling up on the floor. So here's how, as a senior resident, you might address a junior resident of each working type in this scenario. In this circumstance, a driver is going to be worried that they're not executing. So you might say something like, right now, the priority is executing this case well. Walk me through what your plan is for the case. It focuses on results and action and gets to the point. A guardian, on the other hand, is going to be worried that they're missing a detail. So you might say something like, let's quickly triage what's pending so you know nothing critical is on hold. Then you can focus on your step-by-step plan for this case. This creates structure and control and removes the I missed something anxiety. An integrator, on the other hand, is going to feel like they're letting people down by being in the operating room. And so saying something like, thank you for prioritizing being in the OR, even though you have a lot going on, I'm excited to do this case with you and see your progress. This validates that they're not letting anyone down by choosing to be in the operating room and learn. And finally, a pioneer is going to feel that their energy is pulled in too many different directions. And so you might say something like, I know you have a lot going on, but I'm excited to be able to do this case with you. Let's focus your energy here so you can work through this case. It acknowledges the mental overload, but reinforces their engagement. Okay, so we talked about how one of the ways leaders can shape others. Now I'd like to transition into how leaders shape behavior. And Dr. Kendrick is not the pig, but if you were to ask Commander Jeffrey Brandt how he would ideally communicate with people in difficult situations, he'd say, don't wrestle with the pig. You both get dirty and the pig likes it. So in this section, we're going to seek to answer the question, how do we engage in difficult conversations in ways that actually improve performance? And good feedback matters a lot. To tie this back to Carol Dweck, whose research I mentioned at the beginning regarding a growth mindset, she's also well known for the praise study from 1998. After completing a written exam, a group of students were told they were smart, and a group of students were praised because they worked hard. And the group praised for their effort chose harder challenges, persisted longer, and improved performance. This phenomenon has been redemonstrated in several studies over the years, but this is the most famous. And it's really important because it tells us that the type of feedback we give one another directly shapes whether someone avoids or embraces challenge going forward. So how do we give good feedback? Well, Commander Brandt would say, don't blow smoke. And so this is actually one of my favorite critical care facts that I'm really excited to share with you. In 18th century medical practice, tobacco smoke enemas were used in attempts to resuscitate patients, especially drowning victims, based on the fact that nicotine would transiently raise blood pressure. So just like smoke enemas, empty praise isn't effective feedback and doesn't meaningfully improve performance. And now you have a critical care fact. But just like we don't want to give each other empty praise, we also want to make sure we're giving feedback that leads to improvement. And I'll discuss examples of feedback on the on-service slide. But before I do, I want to bring up some guiding principles which have informed my approach to feedback. The first is just having a general awareness of negativity bias. So negativity bias is the psychological tendency for negative experiences to have a stronger impact than positive ones of equal intensity. Negative feedback gets more attention, is processed more deeply, and is remembered longer. As important to leadership as giving good feedback is, so is the ability to receive it. And this is a really good book, especially if feedback is something you're struggling with. It's called Thanks for the Feedback. And the authors describe how we, as the receivers of feedback, create barriers for ourselves to actually hear and integrate the feedback. So their core recommendations are to first expect defensiveness. And I actually think this is much worse for residents. I think about myself. I spent 7 years trying to perfect a craft with basically every waking minute of my day. And now someone's criticizing it. So of course you're going to get defensive. They say you need to internally name that defensiveness. So in your mind, you should be saying, yeah, I am getting defensive right now. And you should own that. They then discuss meeting that defensiveness with curiosity. So instead of saying, well, that just can't be true, shifting your mindset to say, well, what specifically could have given them that impression? So unfortunately, part of being in resident leadership is having hard conversations. And so moving beyond feedback into the more formal, difficult conversations, these two books, Crucial Conversations and Difficult Conversations, have informed my approach to this. And I'd like to share my major take-homes. So again, this has resonated with me because of how effectively this tool has allowed me to navigate hard conversations. So these books talk about how, in approaching a difficult situation, it's important to shift from a blame mindset to considering the contribution of everyone involved. So the moment you stop asking who's at fault and start asking how did we get here, the conversation, it changes entirely. And so in difficult conversations, the authors recommend following these 4 steps. And this is going to feel really esoteric right now, but we're going to go through a specific example a little later. So the first is to make a safe environment for the conversation. Hard conversations should almost always be private, and the person should have an idea of the topic in advance. Then the situation should be addressed using the facts only. Next, step 3, owning your own contribution. This is where you can really diffuse somebody's guardian. This is where you own your contribution and ease their own defensiveness and allows them to actually hear what you're saying. And finally, you open the conversation to their perspective. And again, we're going to go through an example because I know this seems really not specific at the moment. But before I get there, with regards to feedback, I want to raise awareness for some specific research, in particular with the gender gap in resident feedback. Often this is an unconscious practice, and I've gone through now 7 years of residency at 2 different programs, and I've observed these trends in my own feedback and also the feedback I've provided. So first, residents who are female presenting are more likely to receive feedback that's identity laden. Rather than getting feedback like you could retract more effectively with your left hand, women are more likely to get the feedback that they seem unsure. Similarly, women are more likely to receive contradictory feedback across evaluators. And finally, a study using simple data demonstrated that male residents receive greater operative autonomy relative to their performance than their female peers. And I keep these studies in mind as I'm giving feedback to female presenting residents. In particular, I make a conscious effort always to ground my feedback in objective with as many specific examples as possible. And if my feedback is more constructive, I specify the frequency of the occurrence so that female trainees can weigh this against the other feedback they're receiving. Okay, I know I've beaten feedback to a pulp at this point, but I do think it's worth talking about one more thing. So as some of you know, the junior residents have been teaching me a Gen Z word of the day. And oh gosh, this hurts. I've integrated these lessons into an example of how you might give quality feedback to a Gen Z junior after a lab coli. You absolutely devoured that lap coli queen. Closed triangle did not stand a chance. Truly 0 crumbs left. Your dissection was crisp, no chaos, the vibes were immaculate, and you kept your cool the whole time, which is honestly iconic. Only thing is, you had a couple do I send it moments, and bestie, you already know the anatomy. Just commit and go off. But overall, extremely slay, clinically correct, no notes except trust yourself more and keep cooking. Truly surge maxing. Physically hurt. All right, so I'm not going to beat feedback to like a dead horse again because I know we've gotten a lot of training on it, but I do want to give a couple really practical tips that I use as a senior resident on service that I think go a long way. I have a norming statement that I use with junior residents when they come on my service. I say, I will not provide feedback to an attending or to leadership that I have not personally discussed with you. So up front, I try to eliminate a fear that a junior might be blindsided by feedback. Regarding the feedback itself, I actually don't personally ascribe to the 3 positives for every negative to counteract negativity bias. I think a more valuable part of acknowledging negativity bias is to make sure that the overall learning environment you create is positive. For this reason, I make a deliberate point of pointing out in the operating room what juniors are doing well. So for example, I'm not sure you even realized you did this, but when you used the ligature on that, you lifted it up with your left hand to create distance between the liggy and the surrounding structures. That was a good move, and it helped me notice that you're consciously thinking about safety. So Simon Sinek has a lot of good material about this with regards to leadership, where he talks about rewarding the behavior you want repeated. And so generally in the operating room with me, there's a lot of yes, exactly that, nice job. And if I correct you on something, I try to reinforce it with, yes, that's a lot better, nice work. And then formal feedback happens after the case. And it usually starts by asking for permission. Hey, is while you're closing an okay time to discuss the case? Then I typically ask what they felt like went well and what they're going to improve on going forward. But a lot of that is stuff we know. But I did want to focus a little more on difficult conversations, mostly because this is where the rubber has met the road for me. So imagine you're a senior resident and you notice a co-resident that isn't showing up to work on time. Their notes are consistently not completed in a timely manner, etc. How might you address this as the senior on service? And this could be applied to an intern and a medical student or a junior resident with an intern, etc. So I'm going to bring us back to the 4 steps from the Crucial Conversations book. So step 1, make it safe. Say, hey, is there a time this week we can meet and discuss how things are going on service? This isn't a punitive conversation. I just want to get your thoughts. Step 2, share the facts. And it's really important you say only the facts here and not color it with any of emotion about what's going on. So, hey, I've noticed that you've been coming in later than usual and some of your notes haven't been done in a timely fashion. You don't assign blame, you just present the facts only. And at this point, they're probably feeling defensive. So in step 3, you're going to own your contribution. And this is the diffusion step. This is where you help to disarm their guardian. So saying something like, I want to acknowledge that I haven't been the best about creating space for you to let me know if things were getting overwhelming on service. Service has been really busy, and I know I felt like I've had a hard time keeping up. Then finally, step 4, invite their perspective. Can you help me understand what's going on your side? And in using this technique throughout the year and throughout residency in general, I've heard from some of you that you've had a family member being worked up for cancer, or that you've gotten harsh feedback from someone and you're having a hard time coping with it, or that you're feeling burnt out. And these responses dramatically change how you're going to approach step 5 and 6. So if they say, yeah, everything's fine, you can respond with something like, okay, I just wanted to check in and make sure you feel supported. Then in the shared problem solving, how can we set things up so that you're not feeling behind on notes? But really, it just depends on what they say in step 4 and how you're going to approach step 5 and 6. Okay, so we've gone through, I know I'm whipping through this, I'm sorry, but I'm really excited about all this stuff and I'm excited to teach you. But so we've talked about how leaders shape others, how leaders shape behavior. Now I'd like to talk a little bit about how leaders can shape systems. So we have a unique opportunity as residents to be involved in the hiring process for residents in this program. And there's a huge body of business literature about the most objective way to go about hiring. But further, the AAMC has actually consolidated this literature into what they have labeled the holistic review process for resident hiring. So rather than relying on scores alone, the holistic review considers who the applicant is, what they've done, how they perform, all in the context of the program's goals. So the process of holistic review is anchored. So the process of holistic review is anchored in that first step, which is defining the mission and values of your institution and then tailoring the hiring process to those. The evaluation criteria then should all refer back to these values. So for example, if one of your values you're looking for is grit, you're going to create standardized questions and rubrics specifically testing for grit. This process also involves blinding interviewers to scores, training institutions, demographic data, and photographs, as these are all intended to be a part of screening rather than the interview process. So say hypothetically you're a residency program in the Mountain West that's a popular ski destination, and you take your residents out for resident social the night before interviews. Everyone discusses skiing, and the residents report back to the program that a particular medical student would be a good fit for the residency. They had a great conversation about skiing. They had a lot in common, and they got along well. It's someone they feel like they'd really enjoy working with. So this is a situation.
Forgot mountain bike.
Right here. I'm only on one foot. I didn't want to feel too bitter. So this is a situation where you're talking about hiring for a personality fit, right? And so what we're trying to make our goal is hiring for a value fit. So skiing as a sport favors the white upper middle class. You can see by positively reinforcing someone who's a good personality fit, it introduces bias into the hiring process and has the potential to lead to a lack of diversity within the residency. So I bring this up because our residency program actually does this incredibly well. And I want to add a note of encouragement to everybody to participate in the interview process as you move into your 4th year, because the way it's done here could be replicated other places. So the ultimate goal of the holistic review process is to minimize bias in the hiring process. And it has borne out in literature that using holistic review actually improves diversity among teams. But why should we be conscious of having diverse teams? So there's also a lot of literature to reinforce the idea that more diversity within a team leads to a more productive output. So Pixar is one of my favorite examples of this. And so the Pixar Brain Trust was a recurring meeting during film development where directors present rough cuts and a small group of experienced storytellers give direct, unfiltered feedback. The room had no hierarchy. No one, not even the executives, can force anybody to make changes. And the director maintains ownership of all the decisions. They had a culture rule that we don't sugarcoat, we don't prescribe, and we don't take it personally. And the result of this meeting was that expected or invited dissent caused more tension and constructive conflict. But the increase in conflict was then shown to expose blind spots, force clarity of thought, and lead to better solutions. Importantly, it did not lead to consensus. So the goal wasn't to avoid conflict. It was to create the conditions where conflict makes the work better, not the people worse. And really what this entire construct is getting at is how to create an environment of psychological safety that allows productive conflict. And while the Pixar method might not be realistic in all circumstances of our job, like in the middle of a trauma laparotomy, this can be a tool to let in dissent in a controlled way. And tying it all back to business chemistries, you can actually use the business chemistry frameworks to increase the diversity and the productivity of your teams. So, pulling your opposite working types closer has been shown to increase the amount of consternation and often dissatisfaction with your teammates until the end product, which is often more thorough and fleshed out. Understanding your style brings value, and as we talked about before, expanding your own range of styles so you can operate as a well-rounded leader can be helpful. So a method I use to diffuse my own defensiveness or guardianism is to remember that dissent improves the product of my team's output. And when someone brings dissent, I should lean into that, even if someone is questioning my decision making. So on my teams, you hear a lot of phrases like, does anybody see this differently? What am I missing? What do you think? In terms of creating the environment, when someone does raise a concern, you have to respond well. Thank you for pointing that out. Oh, I hadn't thought of it like that. I've noticed on service, Dr. Wise and Dr. Bauman both do this incredibly well. And so pay attention while you're operating with them. Okay, and now to the not at all evidence-based part of this talk. So generations of Brandtisms. There are a few little things that I repeat to myself probably on a daily basis at this point that I think have made me a more effective leader, and so I'm going to pass them from the Brandt family to you guys. The first is perseverance. My grandmother learned to speak English by stealing magazines from her neighbor's trash cans. And so I think if her DNA is anywhere in me, then I'd like to think that perseverance is going to get me far. This is from my dad. Everything is figure-outable. And in the really crazy Sudoku puzzle that is our schedule, this has really helped me out a lot this year. And this one's from me. Sorry, I haven't slept in 25 hours, and this next one always gets me. So growing up, especially being a female athlete, my dad would, going onto the pitch, always say, positive, confident, aggressive, Alyssa. Sorry. And so even now, when I'm going into the operating room or I'm in an interview, he'll call me and say, PCA. And this is where it comes from. And this is a photo of my loop strap. Sorry, I'm so tired. So these are some of my favorite resources on leadership. And some of them I talked about here throughout the talk, but some of them I'd really recommend you guys read. I didn't have time to include them all. For the women in the room in particular, I think A Diary of a CEO is really helpful. This was recommended to by one of my MBA buddies. And before I go much further, I do want to spend some time with thank yous. And so this slide highlights that I really need to charge my phone more often, but it also is just a small example of all the ways that you guys, as the residents, have supported me and taught me to be a good leader. So the way that all of you have shown up for me since I transferred here has made me a better person. So thank you. This is the Alyssa succession plan. I would encourage you all to keep hiring Alyssas in the hiring process. A huge thank you to my co-chiefs who have tolerated a lot of really silly questions from me in the group chat. I showed up as a fourth year, but functionally was an intern in terms of the systems part of this job. Especially to Dr. Cohn, who's been a great friend to me. She transferred me 120 contacts when I first got here, so most of you, I've just looked your names up in my phone and I've magically had them. She's the most memed in the residency, but I'd like to propose an alternative because this is how I see her in the workroom every morning. And being co-admin chiefs with Dr. Sather has truly been a pleasure. She's definitely made me a better leader, and it was so much less daunting knowing that I had you by my side, so thank you. And I also want to thank last year's admin chiefs for believing when I had what it takes to do this role. This is a photo of Chesney and I before I ever even started clinically here. And this is my first intro into the residency, and I knew I'd really like it. To Michelle, Amanda, Jessica, and Sarah, the admin team, I feel like I've gotten a behind the scenes experience this year of how deeply you care for and know our residents. It was pretty common I would roll into somebody's office and start talking about a resident. Without even looking, you'd know what rotation they were on and what they were going through. And so I thank you for your pie days, cookie days, and for all the ways that you've supported the residency here. It's really inspiring. And so when people, especially as a woman, I feel like in a professional setting, you get told to apologize less. And one of the strategies for managing that is to say thank you more. And so instead of saying I'm sorry for all the things I've missed, I just want to say thank you for supporting me and for understanding to my family. Major holidays and things where I showed up 24 hours and turned around and I was only half conscious, and you guys fed me and sent me on my way. I appreciate it. And then to my chosen family, these are all friends I made during my MBA, and they actually, most of these people reviewed this talk in some way or another and have informed it. So anytime you get the chance to make professional friends, especially ones who love to travel, you should embrace that. We take an international trip every year. And oh, this is to Ethan. So I think everybody should get an Ethan when they start residency. Um, I think burnout rates would drop probably by 99%, because how can you have a bad day when you come home and hop on the bike next to that? But I am truly grateful for all of his support and true unadulterated belief in me. And to my emotional support animal, this is Brighton. Some of you may know she was adopted from the streets of Afghanistan after she was hit by a Humvee as a puppy. And this is Timber. He's the reason I need an emotional support animal. And most of the time they get along, but when Timber gets out of line, Brighton keeps him straight. So that's it on the woman in our family. So at Utah, we had a saying that attendings are the enemy. And since coming here, I found that actually really hard to believe. And so I just want to thank some of you guys for making that so difficult. To the Minnesota ACS team, thank you. Dr. Liu especially, the amount of autonomy you gave me on service and trust. I really rely on that when I'm feeling nervous with my new graduate nerves. Dr. McEachron for making me a robotic ACS surgeon. Dr. Kendrick, thank you for your steady, inspiring leadership and for your deep care of the residents here. I wish I could communicate to this half of the room how profoundly he cares for you guys. And to Dr. Brunswold, thank you for hiring me. I love it here. Thank you for building this place into a place I call home. And thank you for taking a chance on me and then backing it up and supporting me ever since I've gotten here. To Dr. McCormick Deaton, thanks for fracturing your foot so we could be boot buddies. And to Dr. Shipman, who taught me that I could drift my scooter on the tile. To the Minnesota MIS team, Doctors Wise, Leslie, and Akramidin, thank you for your patience with me. I came back from surgery on one leg, covering 2 services, and you guys never complained. We're always super kind, with the exception of Dr. Leslie absolutely roasting me in the operating room, which I love. And to the Surgeon team, I got this photo from Chesney's PowerPoint last year, and it's the happiest I've ever seen Dr. Jessen, so I couldn't get rid of it. I made the mistake of saying in the OR that after being a military brat and a surgery resident for 7 years, he couldn't hurt me. But when he found out I ruptured my Achilles, he said, "Welcome to old age," and I cried. To Dr. Tuttle, I actually did this retroperitoneal sarcoma case with him without an Achilles. This was 2 days post-rupture, and he was really patient with me and helped me sort of innovate ways I could work my scooter into being able to stand in the operating room. And I think that made me really believe that I could come back when I did. And to the pediatric surgery team, I want to say this publicly in front of the residents. I think this is the most underrated rotation and probably one of the best pediatric surgery rotations in the entire country. To have this experience here and to not have a fellow and to have the quality of teachers that we have here is unheard of. And I think about this rotation often, especially Dr. Butler. I think about that esophageal anastomosis we did together. And in general, just thank you so much for your patience with me when I had only one junior resident who was out for interviews. I know that was really hard on the service. And to Regents Hospital, thank you guys for your relentless support of me. I don't know if you guys all know this, but Dr. Robbins was actually my chief resident at the University of Utah and preceded me here. A huge thank you again to the Regents Hospital attendings. Dr. Storrs and Keck are sort of the first examples I ever had of what it looks like to be a trauma surgeon and what I want to look like when I grow up. And Dr. Haas, I think, is in a lot of ways responsible for my robotic skills because I would bother her for every single case I possibly could. And again, just a huge thank you to everybody at Regents Hospital. And to the APCs, when I was on rotation, you know, everybody treated me like I was an attending, and it made me believe that I'm ready to graduate and really excited to work with people like this going forward. And to Dr. Shika, who had a lot of wisdom about being an admin chief, who has been relentlessly supportive of me clinically and professionally, and who went out of way. He took me to dinner when I was having a mid-match crisis, whether I wanted to do minimally invasive or maximally invasive surgery, and he was really, really helpful in that. And to Dr. Blee, thank you for hosting your field games each year. You can rest easy knowing that Timber will not be in attendance going forward, and congratulations on your retirement. And I actually couldn't find any photos of Dr. Rosenthal on the website, but I posted this text message here, and I have permission to share it with anybody who wants it. But he saw me in the hallway one day after a really hard case, where I said, you know, I feel like that patient might have had a different outcome if they had a better resident. And this was his response, and I read it all the time. And then to the Methodist folks, Dr. Vietzen, I think I ruined every Monday of his for 6 months straight, because at 7 a.m. I would show up bright-eyed and bushy-tailed, ready to learn everything he had to teach on his busiest day. And man, did he make me a good laparoscopist. You know, to everybody at Methodist, Dr. Bauman is probably one of the best, most well-informed in terms of the formal leadership research. And we've had some really good conversations. I really recommend you guys operate with him and take notes on how he approaches a team dynamic. Dr. Dennis, who let me, you know, push the boundaries of my own operative experience in order to get better. Just tremendous people there. And finally, North, Dr. Kern left my dad a positive voicemail, after a lap chole I did with him, and that got sent through my entire family, both domestically and internationally, and still circulates to this day. And finally, Dr. Davis. Dr. Davis has gotten a lot of panic phone calls from me over the course of the last 2.5 years. When I was trying to decide between minimally invasive and surgical critical care, in true Guardian fashion, I had a spreadsheet with weighted variables on the pros and cons. And he told me it has to be a decision you make with your heart and not with a spreadsheet. And that's hung with me a little bit when I'm over spreadsheeting my life. But he's always been there to listen and send me photos of his dog at the beach, which always calms me down. So thank you from the bottom of my heart, especially to you guys for being my relentless supporters. I admire all of you guys and I appreciate it.
I'm so glad we adopted you.
Thank you. I am too. Yes.
Amazing talk.
Thank you.
I'm so sad I was on maternity while you were at North.
I am too.
One day we'll get to know each other.
I'll be back.
But really, really interesting talk, and I've heard so many positive things from the residents about your leadership skills. My question is about feedback from a junior person to a senior person, which is a little challenging dynamic. And I'm curious if you have any tips and tricks or thoughts in the research that you've done on feedback, if there are any ways to approach that tend to be more successful.
Yeah, and a lot of the research about that is in the environment of psychological safety. And so the way I've applied that on service is I ask for feedback. And I did that a little bit last night in the operating room with Dr. Lane, and I've been trying to be more intentional about it, saying like, hey, I'm learning to assist you. Can you tell me if I can set you up better? Or I'm trying really hard to help you, but I feel like I'm not doing a good job. Can you help me? I think it kind of has to, especially in a residency environment that has a history of harm in that dynamic, I think it has to kind of be led by the senior to open up the safety dynamic there. But beyond that, I think that's probably as far as I've made it.
Alyssa, I'm going to repeat what Julia said. I'm so glad that you joined our program, and it has been great having you as co-admin chief. It's been a pleasure, and I'm excited to have the next year together in critical care.
Me too. Yeah. Thank goodness, because oh my gosh, the schedule's here, guys.
Alyssa, that was awesome. I remember going to Dr. Brunswold's picnic before we started residency, and I remember I chatted with you, and I thought, wow, this resident really does not have much to offer me right now. I feel like she doesn't know anything about what we're doing. And then I later learned that you were new. I'm like, oh, that makes sense. I will be less critical. And I'm also grateful that you just, it's the first time I've ever been compared to Serena Williams, so I'm going to take it. But I remember doing a trauma laparotomy with you at Regents. I remember after the case, my heart rate was so fast. I thought I was going to be tired all night, and I thought, wow, I want to keep doing this. And it was just you and me and Nibby. The staff just watched us do it, and like your confidence and ability to navigate that case was so cool, and it made me realize that like the training's there for a reason. We're going to get to that level, and you were the standard that I thought I wanted to achieve. So it's very awesome.
Thank you. Yeah, I appreciate that. Thank you.
I also want to add something.
Yeah.
So I'm an international student. I just met her like last week, and I always been interested in general surgery, but I ended up in plastic surgery. So in my free time, I went to one of her OR. She was doing cholecystectomy, and I told her, I introduced myself that I'm a medical student, and she literally drew a page and draw the gallbladder and all the drawings and told me this is the conditions that we can like expect and had the relevance, and it was like she literally explained me everything, and I haven't had any resident doing, if even they're busy, they don't like, they explain but they don't visualize the things, but I really appreciate that. And it's a very short meeting, but I'm grateful that I met you.
We can still convert you from plastics. There's still time. Go ahead, Ashley.
I have so many words, and I'm also speechless about how I feel about you, which I think is a great summary of how great of a leader and mentor you've been for all of us junior residents. And working with you on Regents EGS, you made the long days fly by, and you taught me so much about surgery and life. And thank you from all of us, and I'm really glad you'll be here another year.
Thank you.
I've never been more honored to be compared to you and thought of your sister. I still will never forget the patients being like, what's going on?
Alyssa, I just wanted to piggyback on what Ashlyn said. I think a lot of us look up to you what it means to be a role model and a surgical leader, especially for us women. So thank you so much for when I'm panicking and calling in the middle of the night for leadership lessons, scheduling problems, life problems, and in and out of for all the teaching that you've given all of us.
Thank you. You're gonna make me cry again.
I would say, we're really, this turned out to be just a fantastic get for us to be able to hire you into our program. I would say that, you have a strong commitment to patients. You're technically excellent. Excuse me. Your leadership is really, evident throughout. Obviously, you were recognized by your peers as a leader after not having been in the program for the whole time. You were new, and people identified that right away. And I would say one of the things that was most impressive is that after you had been here for seconds, I started getting texts from students and juniors about how great you are at teaching, and your commitment to the juniors and to the students that are on your service, that their experience be a good experience, a psychologically safe experience, and one where they can develop. And so I think that has been really impressive. I, again, will just say, how glad we are to have had you in our program, and how you made us much better for having been here. So thank you.
Yeah, I would echo that. Obviously, I've given you this feedback personally, but publicly, I think that it's really inspirational in the short time that you've been here, what an impact you've had. The people around you, like staff, the trainees, our culture, your kind of relentless, gritty leadership by example, not telling people what to do, but showing them kind of as a person above them or below them, like how you conduct yourself has rippling impacts throughout. And so I think it inspires people to be better. You hear the feedback, you've been hearing it, and I'm grateful that you were able to join us for the time that you have. I'm sad that we didn't get you from the start, but I'm super excited that you'll be staying with us for an additional year and continuing to have impact on our clinical and kind of community environment. And just from the bottom of my heart, thank you for all the work that you've done.
My favorite part of this talk is that I get to introduce my colleague. So, if it's okay, I would like to move forward and introduce Dr. Jessen. So, Dr. Jessen was born in Salt Lake City, Utah. She grew up in Fort Dodge, Iowa, and I'm going to say this wrong, and every Midwesterner is going to be upset. Eau Claire, Wisconsin. She did her undergrad at McAllister College in St. Paul, did 2 gap years working as a scribe and coaching hockey while waiting for her now wife to graduate. She attended Medical College of Wisconsin for medical school and is planning to be an ACS surgeon at Fairview St. John's in Woodwinds next year. I was trying to come up with some dirt to introduce her. The only 2 things I could think of was the Utah residency had an award for most likely to have a heart rate of 40, both in the trauma bay and on the ski slopes. And I honestly think that fits Dr. Jessen well. She was awarded a teaching award last year at graduation, and so I thought to reach out to the juniors and ask them, if you could describe Dr. Jessen in 1 word, what would you say? And several said compassionate, many said calm, several said skilled, and that is my experience of her as well. And so, without further ado, Dr. Jessen.
Thank you so much. So, I actually texted Alyssa this weekend and said, what can I do to not follow you? She had a really good reason, unfortunately, so here I am. And for my chief talk, I've been thinking about it for years about what I could talk about, and most of that time was spent thinking about how I could actually not give a chief talk, because first of all, I don't know anything interesting about anything interesting, and no one wants to listen to me talk for an hour. And I told myself that if I got up here as a chief resident and looked out in this room, somebody probably on this side of the room would realize that this has been a 5-year-long mistake and I'm actually a fraud. So that made me realize that the one thing that is very near but not at all dear to my heart is being an imposter. So today I'd like to talk with you about imposter syndrome, more commonly known, or more accurately known as imposter phenomenon, which is an experience I think that a lot of us probably share but don't talk about. I'm going to tell you a lot of things that you already know, but I hope that you'll leave here today thinking differently about them. No financial disclosures. I will be showing many low-quality pictures of pictures. I am by no means an academic expert on imposter syndrome, and it's my own personal highest level of imposter irony that I'm standing here in this room talking to you about imposter syndrome. If you already know this topic doesn't apply to you, I'm really happy for you, and you're welcome to leave. I will not be offended, and depending on who you are, I might even be a little relieved. So, by way of formal introduction, my legal name is Hannah Tui Jessen. When my wife Chris and I got married, we decided to honor our maternal lineage by taking our mother's maiden names as our middle and last name. We intentionally chose Jessen as our last name because by most white Midwestern standards, it's pretty easy to spell. But early in my intern year, that proved to be incorrect. A very, very common theme is Jensen, which I'm flattered. Some had a variation on the theme. Some people would throw in 2 S's. They would take out the N. They would take off an H. Some people would change my middle initial. This one got really close, but 1 letter off. Some of them got even more creative. Jennen, Jepsen, Jansen. GME used the traditional middle first name combo. This one was somehow officially logged in Epic. I'm not sure how that happened. Hessen, I think, was maybe a typo, but I'm not sure. One of the family favorites has become Jessen. My in-laws love to call me Dr. Jessen. Dr. Hansen knows who they are, and they combined my first and last name for 4 years. Transplant fellow Dr. Hannah was an on-the-job promotion. So it continues, but one of the kind of weirdest ones was when I was referred to as my maiden name, which is nowhere in any of the University of Minnesota records. So all of these have provided comic relief to me and my family over the years, but also especially as a junior resident where I already felt like I was kind of an evil magician for tricking the program to accepting me. Each of these typos was a small micro reminder of whether or not I belonged and fed into the insecurities I had about my personal identity and sense of belonging here. And I suspect that I'm not the only one that's felt like that, whether you're the PGY2 in Duluth or the chair of the department. So as a general overview, we'll talk about what imposter phenomenon is and how to recognize it, how we can measure it. We'll talk briefly about the roles and attitudes within surgical culture and how they might potentially foster imposterism. And finally, some of the things that we can do to thrive as imposters. There are no chief talk rules that I've been made aware of, so I'll give some unsolicited advice and thank yous before we make it into a full circle moment and end with my chief outro. So historically, Doctors Pauline Rose Clance and Suzanne Imes originally described the term imposter phenomenon in their landmark paper, The Imposter Phenomenon on High Achieving Women. This was published in 1978. Essentially, they interviewed 150 highly successful women in various professions, and they defined it as an internal experience of intellectual phoniness. All of these women shared this common feeling of chronic self-doubt and constant fear of being discovered as a fraud despite their demonstrated achievements. Notably, this is not a syndrome. The naming of it was intentional by the researchers. It's not a diagnosis or clinical syndrome, though this has been largely adopted in the mainstream media. The term imposter was intentionally selected to honor one of the women and how she originally described her experience. People with imposter syndrome attribute success to external factors like luck and help and the oversight of others, while all failure is internalized. They tend to discount any positive feedback, and any criticism or complication becomes confirmation of how they feel. There's robust literature supporting the correlation between experiencing imposter phenomenon and things like generalized anxiety, depression, low self-esteem, burnout, suicide, etc. And it has been shown to have harmful effects on job performance and job satisfaction. And the literature also shows us that these feelings don't tend to go away over time, and they don't also tend to improve significantly with achievement. So if you're thinking, this is not ideal, but I don't really have to worry about it because this will go away once I'm unattending, I'm really sorry, but it probably won't unless you start to work on it now. So if you're questioning whether you might have imposter phenomenon, let's talk a bit about how it might manifest. Essentially, once you've identified a task, whether that's been self-assigned or assigned to you, you incorporate your own high drive to succeed and high standards, which we love, but then self-doubt and fear of failure and negative internal monologues start to creep in, and this creates anxiety. And anxiety sends you down one of two paths. You either become an over-preparer or a procrastinator. The over-preparer might spend, 60 minutes working on a 2-minute presentation, and they believe that their success is because they had to work harder than others and due to this unsustainable level of effort. A procrastinator becomes paralyzed by self-doubt, self-fear, and they tend to throw something together at the last minute, wing it, and so they attribute their success to luck or fooling others. And I have to say that learning about this has been such a relief because I always thought I was just lazy, but it was actually just my imposter phenomenon. So Dr. Valerie Young, who developed the imposter Syndrome Institute proposed that failure and the shame that follows it is determined by how you define competence for yourself. And she described these 5 competence types, and you might relate to more than one. The perfectionist needs to be in the driver's seat. This is the most common type of imposter syndrome, and they're concerned about how things get done. They set excessively high standards for themselves with expectation to deliver a product or performance with no flaws. There are no room for mistakes. Perfectionists like to be in control and often feel like if you want something done right, you have to do it yourself. They hyperfixate on the micro details, which leads them to either procrastinating or over-preparing. And they might also avoid things altogether if they fear that they can't do them perfectly. The natural genius, like perfectionists, their expectations are also impossibly high, but their competence is determined by having innate abilities or intelligence to do something. If you take too long or you struggle, that's failure. They can be overly optimistic about how long it might take them to do something. And the natural genius probably didn't have to study much in school, but as they reach higher levels of academia, they interpret things not coming easily as signs of incompetence. Likewise, they might avoid taking risks in case they fail. The soloist, this person believes that if they don't do something on their own without help, it doesn't count. They see needing help as a sign of failure. The expert, these people feel like they have to know it all to be competent. Instead of seeing knowledge gaps as opportunities, they view them as failures. They deeply fear being exposed as inexperienced or unintelligent and can procrastinate by endlessly seeking out more information. They might get multiple degrees to confirm this for themselves. They also might not offer their opinion to the group for fear of a knowledge gap being exposed. Finally, the superhuman. These people want to do it all. They expect to fulfill all of their life roles as spouse, parent, friend, sibling, and surgeon with perfection and ease. Their competence comes from how many things they can juggle at one time and have a hard time saying no. So now that we recognize it, scientists love to measure things. And so for clinical and research purposes, Dr. Clance developed the Clance Imposter Phenomenon Scale. This has become the gold standard for measuring IP severity. It's a validated survey that consists of 20 questions on a 5-point Likert scale with a score of 61, 62, and above as the cutoff for clinical severity. If you're curious, I'd encourage you to take the SIPS test, which can help validate your experience and might give you a sense for what the role of IP is in your life, and I hope will motivate you to begin to tackle it. So when researchers do measure it, what does it show? Importantly, it shows us that we're not alone, especially in medicine. While imposter phenomenon was originally investigated among white women, this experience has been identified in high levels among both men and women across various ethnicities and age groups all over the world. Henning et al. Was one of the first to look at the impact of IP and perfectionism within the medical community among med students. Interestingly, they found that perfectionism among med students was similar to the general population, but the rates of IP among med students was significantly higher and was correlated with high levels of distress. This sparked the academic interest of examining IP among medical professionals, and subsequent studies consistently show high levels of IP among med students and residents. In one meta-analysis, residents had rates of 41% and 24% in women and men. These studies again demonstrated the association with poor mental health and suicidal ideation, which is especially powerful and important to acknowledge, I think, because the most recent resident cause of death publication in JAMA 2025, the #1 cause of death among residents and fellows was suicide. And they don't comment on causality, which is outside of the scope of their paper, but I found it really interesting that the majority of resident suicides occur in the first academic quarter of first year, where you've just taken a gigantic step outside your comfort zone onto a steep learning curve with high expectations. A few studies have looked specifically at surgeons and surgical trainees. For example, this study published in 2021 by Baum et al. In the Journal of American College of Surgeons examined the rate of IP among general surgery residents across 6 ACGME accredited academic general surgery training programs similar to ours. Their results found that 97.9% of general surgery residents who responded to the survey had moderate, significant, or intense IP, with 76% of those being in the top 2 tiers. They felt like their response rate of 141 out of 309 was pretty good for residents. And all of these studies are subject to survey biases, but I would argue that even if all 168 of the other residents who didn't respond had no imposter syndrome, the rate would still be 44%. Notably, they did not find any correlation with sex, race, age, postgraduate year, or STEP or AppSite score. So what should we do about it? A lot of the literature, and especially mainstream media and TikTok's self-help culture, have a lot of ideas, but they tend to use language that pathologizes imposter syndrome and putting the onus on the individual or the person that's experiencing it to fix it. And what gets neglected, I think, is the role that institutions and systems play in perpetuating imposterism. In fact, the overall culture of medicine itself has been cited as a risk factor for imposter syndrome. As surgical trainees, we're taught early that the best surgeons are sometimes wrong, but never in doubt, which speaks to the ethos of being decisive and confident in taking action. And while these traits are useful in the right context, how does a trainee who is chronically in self-doubt, like me whenever I had to wear a dress or do makeup, reconcile this with their personal identity? So let's talk briefly about the culture of surgery, which is a unique microcosm within the culture of medicine. A group of researchers in the UK sought to understand which attitudes, values, and behaviors in surgical culture contribute to how surgeons and surgical trainees develop their own professional identity. They used interview and observational data to explore what surgeons believed are core to becoming or being a surgeon. From this, they identified these 6 major themes, and I'd like to discuss a few of them. Number 1, attitudes of perfectionism. As surgeons, we're taught to value precision. We learn to be wary of operative shortcuts and trying to get away with it. The surgical culture and patient expectations reinforce individual perfectionism, which in itself is a very useful trait. Everyone wants their surgeon to be a perfectionist. However, while adaptive perfectionism allows for an occasional mistake, maladaptive perfectionism is driven by fear of failure and concealing your personal imperfections to the point that you doubt your own actions and can become paralyzed by it. Throughout the literature, maladaptive perfectionism is associated with similar detrimental health effects as IP, including anxiety, depression, psychological distress, and burnout. Attitudes of accountability and service. We're taught that the surgical community values a sense of duty and commitment to patients. This is a very famous text page among our class, and I applaud Alyssa for not blocking out the name. So Jay actually sent me this page one night when I was at puppy kindergarten class. We're taught that you should sleep, eat, and pee when you can, but probably not on your 28-hour shift. Self-management behavior and personal resilience. We're taught how to conduct ourselves during high-stakes operative steps, how to manage complications, and how to appear confident through it all. We're to command the room and be the trauma team leader, and then go to Charlie Pod and discuss postprandial pain a few minutes after calling the time of death. Number 4, this one is my favorite. Self-critique and seemingly neurotic behavior. Surgeons love to claim that they do things in the OR to sleep at night, but then they text the junior resident at 2 a.m. like, why haven't the labs been drawn? So the high standards we set for ourselves and others undoubtedly make us better surgeons, and mastery of this hidden behaviors curriculum is part of that. But where's the line between excellent surgical training and developing harmful habits? Recognizing when attitudes become maladaptive can be difficult, and it's easy to see how someone struggling with chronic self-doubt and fear of failure, who misattributes both compliments and critique, might interpret all of these themes as fuel on their imposterism fire. So, what can we do about it? Unfortunately, none of you are going to walk out of here today being free from your imposter syndrome, but I do hope that with a little bit of work, you can make your imposter syndrome work for you and not against you. First of all, we have to recognize that we're not alone and we need to talk about it. If you take nothing else away from this talk, my one hope is that someone somewhere, hopefully on this side of the room, will feel a little bit less alone with their imposter syndrome. One of the best things we can do as individuals to mitigate it is to talk about it. Talk about it with friends, trusted colleagues, mentors, therapists. As residents, what we choose to talk about with each other is one of the easiest ways that we can shape our culture. You have to reframe it and rename it. I'd argue that if you have imposter phenomenon, you're doing something right. It's context dependent, and we feel like imposters when we're stepping out of our comfort zone or trying something new. And that should be celebrated. Learn how to reframe your imposter feelings. Situations that make you feel vulnerable are now learning opportunities. Your tendency toward perfectionism should be fostered and will make you a great surgeon, but you have to allow for occasional mistakes. Learning how to recognize it. Pay attention to your own inner monologue. Recognize when positive feedback makes you feel uncomfortable or when you're struggling to ask for help. Finally, keep track of the evidence. Write down your little wins or nice things people have said and actually look at it. Celebrate your success. And remember, feelings aren't facts. One tool that I learned from Brene Brown several years ago and have incorporated into my own life is the story I'm telling myself. So I might say something like, the story I'm telling myself is that if I go to that case, Dr. Jensen's going to ask me something about colorectal liver mets that I don't know, and he's going to realize that I don't belong here. The story you're telling yourself is not always reality. Try to decouple your self-worth from your achievements. Easier said than done. And finally, try mentoring a trainee, a med student, or a junior resident. This is an easy way to rebuild some confidence and faith in your ability or knowledge. Interns, when that new group of interns comes at the end of June, you're going to realize that you know a ton. But it's not all within our individual control. There are deeply rooted historic levels of stigma and oppression working against us. So what can others do? Again, I think we need to talk about it. As a senior resident or staff, be open and vulnerable, especially with trainees and juniors. Talk about the times you might have felt like an academic fraud or not known at all. Similarly, normalize lifelong learning in medicine and encourage a growth mindset in your learners. To foster that psychologically safe learning environment where it's okay to explore knowledge gaps. Learn to recognize it. Try to notice the resident who seemingly avoids coming to the OR, hesitates to speak up on rounds. Maybe they dismiss positive feedback or spend a lot of time perfecting their progress notes. Maybe they're trying to do it all on their own or doesn't ask for help. These behaviors, of course, can be for a variety of reasons, but discussing imposter phenomenon early might change that resident's trajectory. Remember, it's not just the learners who are underperforming who might be struggling. And finally, as a big, broad, sweeping statement, we have to continue all the other work that we do to break down biases, stigma, stereotypes, and the layers of oppression that might be contributing to the development and maintenance of imposterism, especially among people of marginalized and minority groups. And with that, I'm going to ask you to think about your questions, but save them, because we're going to get to the good stuff. So just some brief unsolicited advice. One of the best pieces of advice I got on my first day was not to tell anyone you're coming home until you've left the building. Not when you're leaving the workroom, not when you're in the stairwell. This story I tell myself tool works really great in relationships too. Dr. McCormick a few years ago gave a talk, and one of her takeaway points was host the barbecue, which just means you're going to be giving your chief talk before you know it, and you should make the most. You have to live through residency, so host the barbecue. No one has time, but people will show up. Okay, this is key. Next sandwich day at Regents, you have to try the Dr. S. Huberty. I've listed the recipe here. Highly recommend. And then I was thinking about maybe just telling one successor about this fact, but I'm going to tell all of you, so you're going to have to share. But the OR 10 observation room in 4A is really good for naps.
I've been holding on our co-residents, our chief co-residents. Just want to let everyone know. I've never heard that before.
I mean, you still have to figure out the code on your own, but Finally, this is one of my favorite quotes and something that I try to live by. And I think in surgery, we don't talk enough about how powerful the immeasurable impact is on the patient and their family when they feel like their surgeon tried and cared. You don't have to know it all. And I did get a full night of sleep last night, but we're going to try to get through these thank yous. So we get to operate with a lot of different surgeons in our training, and they've all taught me something. Many of them let us do the operating, and fewer of those actively teach us to operate. And of the people who do both, over time, several of them will become the voices in your head. So in our university system, these are some of the people I have to thank for that. This includes former chiefs that I've had who I've now had the opportunity to work with as staff, and I'm really grateful for them. This extends, of course, beyond our university. These are some of the people at our non-university sites that have been instrumental in my technical skills, and I'm really grateful for their patience and time. Then there's a group of people who have a very unique and important role of protecting the patients from me and protecting me from staff. And all of them have prioritized my surgical training. Megan Goff has also prioritized my physical training, and I'm literally stronger because of it. I'm just really so grateful to all of them. Finally, chief outro. So buckle up because there's going to be a lot of photos. And in my defense, I was in the last class before we started the intern intro, so all of this content should be new to you. I was born in Salt Lake City, Utah. Some of my photos aren't showing up. That's okay. To Ben and Lori Whitus, who were, my dad was completing his interventional radiology residency in Utah. My mom was Dr. Jessen for one day before she married my dad the day after medical school graduation. My grandparents, a psychiatrist, an artist, a teacher, and a pastor, were a big part of my life growing up. My grandfathers, who are now 89 and 92 years old, are still politically and socially active in their communities. My parents never pushed me into medicine, but my mom always thought I'd probably be a good surgeon because of how well I could back up a trailer. They have been endlessly supportive of me and my dreams, and I can't thank them enough. And I just want to highlight this picture in the middle of my dad, who came out of marathon retirement to train again and run my first marathon with me in the Twin Cities. I've been blessed to have 3 younger brothers who have turned into incredible humans and some of my best friends. Their life partners have expanded our family, and we've been able to travel the world together. These are my in-laws, Tim and Christy. Tim is a retired fighter pilot in the Air Force and now regional chief pilot for UPS. It was not at all stressful when I told him that I wanted to marry his only daughter. My mother-in-law, Christy, quite literally does everything else. She's a master gift giver, and both of them have been beyond supportive of me over the last 10 years. The one thing that gets me off the couch after work is hockey, which I played growing up and continue to play through college at McAllister on the club team, and then found a way to continue playing through residency. My teammates are great because they have absolutely no idea what a general surgery resident does or is, and somehow that's actually been really refreshing. This is kind of a shameless plug, but during my time here, Minnesota has gotten its own professional women's hockey team, the Minnesota Frost, who are now 2-time back-to-back world champions. They play at the Grand Casino Arena. Please go see them, and it's been really fun to see some games with people from the program. To my co-residents, you guys are what make being at work tolerable and even fun sometimes. It's been a pleasure to learn from you and operate with you. Thanks for getting me outside the house as well. A special shout out to my original intern class and my current chief class, who I go to with all my dumb questions and who are a source of endless entertainment in our group chat. The hardest part of this whole thing was fitting Teddy on one slide. So we got Teddy about a year ago, and I'm absolutely obsessed with him. He gets me outside. He greets me when I come home every day. And I did sneak some photos of him into the slideshow this morning. finally, Chris, who's here today. I know that some people hate on it, but getting gay married was one of the best things I've ever done. Luckily for me, we got married before I told her I wanted to be a surgeon, and despite this, she has stuck with me. She has waged her own personal battle against my imposter feelings and forces me to sit with my positive feedback until I internalize it. And this would absolutely not have been possible without her. And then finally, as you know, pending final negotiation contracts, I'm excited to say that I will be joining former Chief Royalties Matt Robertson and Keith Worth at Fairview, St. John's, and Woodlands as an ACS surgeon next year.
Anna, that was Dr. Jessen. I probably misspelled your name 5%. Eventually learned it, so thank you for coming through it and really bringing this topic up. As I tell our new staff who are maturing in things, that the first year out is tough, and if anyone ever says it wasn't, they're lying. And I think anyone who says that at some point in their training, their career, whatever, they haven't felt imposter syndrome or the imposterism, they're not being truthful. I think it's probably much higher than what you said.
Yeah.
During times, whether we all have it all the time. But I think an important part is the strength of our spouses. None of us would get here without them, or the supportive family through all this, because what we do is not done. Yeah. And hopefully, when people come to our service, which I think probably breeds some of this a little bit, because you suddenly have a content that is totally different from what you're doing the other 6 3/4 years through your training program. Just talk to us. We're here. We know that. It's just surgery is the same sort of thing. So it's a great topic. Thank you so much for talking about it.
Thank you.
I want to echo the thanks to both of you for bringing up these topics. I don't think I'll ever be able to speak Gen Z, but videos again, because this is complex. And, for older trainees like me, we're still on the track. It's still learning, and I have no issue that either of you will be imposter. See, I have huge confidence, but confidence, it seems like confidence and competence ride on different tracks. Yeah. And so this is part of it. And it's I think you're both outstanding. We're just so delighted to have you doing this. I congratulate both of you for.
Thanks.
Well said, James. I'm struck by the data, like 97%.
Yeah.
That absolutely speaks to a cultural issue, right? Not a personal issue, despite a huge volume of communities feeling that. So your openness in sharing your own experiences and raising awareness is, I mean, changing culture takes time, but that's one of the really first steps is to normalize that you're not alone in feeling this, and that there are things that are changing and still need to and I really appreciate you kind of from your role as kind of this quiet and calm, and from outside perception, kind of this like fearless leader to share your own kind of internal self-doubt is really takes a lot of strength, and I think a lot of people are going to learn from that and be inspired by it. So thank you.
I as somebody who has, stage 2, 3 syndrome pretty regularly, I really appreciated this talk, and I do think it's really important to bring it out into light, like echoing what Dr. Kendrick said about saying, most of us have this, and that it's really important. I think partly because we're in a career where if we make a mistake, somebody can die. I think that kind of emphasizes what's probably already there in a lot of other fields as well. But I do think it really impacts. So thanks for bringing that forward. I would also echo the comments about, you being a tremendously accomplished surgeon. You're excellent technically. You have really great judgment. And I think one of the things that is potentially underappreciated, I know not by Dan, not by me, but you demonstrate quiet leadership that emphasizes, deep listening, humility, and thoughtful action over kind of being the loudest voice in the room. And I think that your leadership power as a result is really multiplied. And so I think people lean in to hear what you have to say because you don't share your thoughts, you don't overshare. So people really value, hang on the words that you say. Pardon me. So again, as I said once already, you have made us better for being here. I think, one of the greatest things about having been part of the program is seeing where people go and being really proud of the graduates in our program. And you are another person, who will be in our area that we can be really proud of. So thank you.
Then one last question, or for me at least, Hannah. So when you're over in Woodwinds, if you have someone who's 17 years,
He's gonna do
That's
that.
a child. Child.
and weighs 110 kilos,
He's gonna do the appendix.
That appendix is coming out. There was smoking and we were out.
As someone who has been called Hannah lately in the operating room in the 5th year of your residency and the 7th year of mine, I'm very glad to be graduating with you, and I'm very honored to be carrying your name.
Comment and a question. I don't know if I've told you this, but I remember meeting you online on the pre-interview social thing, and then talking about you in this room when we go through your meetings. And a lot of people remembered you and advocated for you to come here, and we were all happy that you did. But I remember back that far, and then being able to be a classmate with you these past 2 years has been really awesome, and a friend and a female sports fanatic together. Question is, in terms of imposter phenomenon and this, I agree with you, if there's 90-something 100% of people, respondents at least, that's a systems issue. Did you come across any data about how to approach changing a system or system changes that would be helpful for this kind of thing?
I would say the literature on this topic has kind of exploded over the last 8 years or so, and still most of it is trying to quantify imposter syndrome. Almost nobody, a lot of the papers will say, is it the chicken or the egg? Is it people who are selecting themselves towards surgery, or is it surgery itself that helps foster this? But none of them that I found start to broach the system issue.
Did a journal club at Regents recently one of the articles was about imposter phenomenon. And one of the most striking thing from that article was that, for me, was that leaving little room for doubt is makes it worse, or is sort of an inciting factor. And I felt, just like you said, that's one of the main sayings in surgery is never, sometimes wrong, but never in doubt.
Yes.
This is what you're doing. Awesome.
Yep. Here's what I
Keep being awesome.
I can see what you're trying to do. Yes.
Again, you're another person who I have so many words for, and I'm also speechless about. The fact that you gave this talk, I think, is very telling to a kind of leader you are. And I know you're gonna have to sit with this with Chris later and actually listen to it and feel it. But I still remember as an intern, Nargis giving me sign out, and you were her chief, and I said, "What's Hannah like? I haven't worked with her. What's Dr. Jessen like?" And she just said, "You're gonna love her. She's a fantastic teacher," and that everything has proved to be true. And I think I speak for all juniors when we're all excited to operate with you. We're all excited to learn from you. And echoing what Dr. Brunswold said, when you say something, I think everyone really does listen. So thank you for everything you have taught us. You're gonna have to sit with all that.
It's for later.
Hannah, I have said this to a million people, and I just go, "Ugh, Hannah, the best." Or somebody will say something about you, and we just go, "Oh, she's the best." And just, everyone else has all kinds of words, but it's the truth. My heart rate when you walk in the room, just in a casual conversation, goes down to like 40, just because you're the best, and we love you, and so glad to be one of your co-chiefs.
Thank you.
Yeah, Hannah, it's been a real pleasure and privilege to get to know you and work with you over the last couple of years, professionally and as a friend. Despite whatever internal storm and external storm, you're always very dependable and measured, and I respect that quite a bit. And we are very lucky to keep you in the Twin Cities. St. John's is wildly lucky to have you as staff.
Thanks.
Yeah, I think similar to what I said with Alyssa too, I think a lot of us look up to you for what it means to be a leader in surgical residency and even beyond. And I think I'll also speak for Ross when I say, we were baby interns when you mentored us in a lot of rotations, me and Ross specifically, and we are so grateful for everything. And now that I look back on how you conducted yourself when you were a senior resident, I tried to and failed to emulate how you were.
Thank you.
The most frustrating thing about you is that you're completely unroastable.
Yes.
I tried to put some pictures in.
I just want to echo what everyone's been saying. Yeah, as a leader, you've been fantastic. I remember as an intern, there was we just did an umbilical hernia at Regions, and before the case, you were like, okay, these are the steps that you want to do. And it was the first time that someone walked me through the procedure so that I could go from kind of that first assist to maybe a surgeon junior spot, and you kind of taking the mentorship role. And that just meant a lot to me. I mean, everyone here loves you. That's an understatement. I think Ashlyn and I jokingly asked you why, how it is that everyone likes you so much, and you said, well, it's easy to be liked when you don't talk a lot, which didn't internalize at all and did not take any of the quiet advice that was underlying that statement. It's also just affirming for, I think, anyone here who seeing your trajectory going on, just matching into ACS now that you went straight through, and knowing that you can get jobs and thinking about fellowship and balance and all those things. It's reaffirming for someone who's not sure about doing fellowship, you can be absolutely fantastic. This program trains great surgeons, and you're a fantastic example of that.
I want to give a shout out to the feeling circles that we have every once in a while, because I've not gotten to work with you or Shelby as part of our rotations, and everything that you both say has helped me grow the little bit of confidence that I have as an intern. So I take what you say very seriously, and I'm grateful for that.
Thank you.
If I can just make a final comment on the Chiefs talks, I can't let a teachable moment go by. Really think the two of you today and all the Chiefs this year, the whole goal of the Chiefs talks, the way it's explained to me back, as Jeff would always say, in the plasticine era, way back when, was to teach something to the faculty and the other residents. It didn't matter what it was about, but teach us something, because it's often harder to get up and speak in front of people you know well than it is in a public forum. So that was a goal. Thank you guys so much for teaching us great stuff. That makes us all better. So I appreciate it. Didn't mean to kill the mood.